hello to everyone. Okay. Say hello to everyone and now go off, please. Before he bombards again.
Okay.
So we are live on YouTube. We can
So you
begin.
can start, sir.
I guess, Mridhi, you can start.
Hello, everybody. Evolutus India is happy to get everybody together on this platform. Rolflex Tonic is something which is a new product for all of us. And our product manager, Girish, is here, who has organized everything from, brought everybody together.
So you can start, sir.
Girish. Please introduce
Thank you, all
everybody.
of you, sir. It's already 4 o'clock.
Yes,
I
Mridhi,
thought
you
we had
can
to
start.
start. And Dr. Premkumar also will join very soon.
Evolutus India is
Yes, sir.
happy.
Please. Manisha, sir, please go ahead, sir.
Yes. Today, I'm talking about a digital system for performing total knee replacement. It is a CT-based 3D planning system with image-derived modular instrumentation. The CT scan center directly uploads the CT scan on the web server. So the raw data itself is exported. There is no processing of data. There is no reporting. Because the gap between two slices of the CT scan is 1 millimeter, the accuracy of planning is 1 millimeter. Once the CT scan gets uploaded on the server, Knee3Viz artificial intelligence and machine learning algorithms process the CT scan and upload it back on the web server for the surgeon. The surgeon can then work remotely on any laptop with an internet connection. Few of the unique planning features which are available in 3 dimensions. Both mechanical and anatomic axis for the femur can be calibrated in the AP plane, and because of that, any instrumentation can be performed. You can use extramedullary, intramedullary, or the Knee3Viz modular jig. This is probably the first digital system wherein both mechanical and anatomic axis can be calibrated in the lateral plane as well. And because of that, the amount of flexion of the femoral component can be very accurately determined. On the 3D model, it is very easy to pick up the accurate transepicondylar axis, both on the basis of anatomy as well as on the basis of the sphere of the condyle, to find out the true axis of rotation. All this data is then with you as you plan the knee. The valgus angle, the flexion of the canal or the shaft of the femur, and the rotation. Similarly, on the tibial side, quite often for Asian patients, we have seen that the slopes are excessive. Knowing individual medial condyle and lateral condyle posterior slopes helps to set both the rotation as well as the slope of the tibial component. Overhang of the component can also be evaluated very easily. Plus, because the patella is in the natural position, rotation of the femur can be set properly. The curve of the implant and the curve of the native bone can be seen and matched properly. This is probably the first system wherein you can actually visualize the mid-flexion instability. So effectively, it's an ideal post-COVID-19 planning tool. Precise anatomic definition for the individual, more kinematic alignment in all three planes within 2 to 3 degrees from the natural anatomy, compatible with work remotely. And because all planning is detached from the operation theater, it lessens the operative time. It reduces the surgeon exposure risk. It reduces the number of personnel and equipment inside the OT. Just a brief preview. In the coronal plane, it's very easy to align both the sulcus of the implant and the femur. Possible to see where the tibial keel is going in, the anterior overhang, stuffing of the patellofemoral, similarly the posterior offset, overhang of the posterior condyle, and you can see the curve on the curve, see how it matches, the slope, the keel inclination, mediolateral overhang, and the patellofemoral joint articulation. We know that when these measurements, accurate measurements, are available in millimeters, it is possible to avoid intramedullary intervention. Same principle used for computer navigation, for patient-specific. So what did we do? Simple modular reusable jig. Once we know the difference in the cuts, place bushings, set the height, and we are good to go. We know the distance, we set the bushings, because the jig sits on directly onto the femur with 5-point contact, it locks itself in one unique position. The 5 points of contact being 2 posterior condyles, medial and lateral distal condyle, and anteriorly. So with these 5, it locks itself in one position, and then all you need to do is to pin for the 4-in-1 block and for the distal block. No intramedullary intervention, and it's locked in one unique position. For the patient in the hospital, it saves time, less instrumentation, cost effective, highly accurate, and there is no intramedullary violation. Is this accurate? What about the comparison with other digital technologies? We've known digital technologies in TKR for decades now. Computers form the heart of this digital technology. And what works here is, because the bony structures and their relationships do not change from image capture to surgical intervention. Once you take a CT scan, the relationship of the condyle to the head of the femur does not change from that time to the time that you operate and take the cut. Unlike the bowels, which keep on moving. Thus, From image capture to surgical intervention, it can guide the surgeon with precision. But the accuracy is dependent on data input, which is image capture and landmark identification. Processing is simple computer, but the data output leads to precision of cut. If there is garbage inside, at the time of input, it is going to be garbage outside. Now let's look at the accuracy of image capture. What are the modes of image capture that we know of? X-rays. We know that 2D imaging is inaccurate. Lately, artificial intelligence programs are available which can convert two orthogonal 2D images into 3D. But then they are based on a large data set and are not specific for that particular individual. 3D, we know that yes, the image capture has an accuracy of 1 mm. In imageless surgery, surgeon maps the bone, and there can be unquantified errors in the sense that when the person is mapping the bone, there can be some capture of air points, which can throw the entire calculations out of gear. Before we move on to landmark identification, we know that there are two major methods of image capture: 3-dimension imaging and imageless. So we'll divide that into two groups as we discuss landmark identification. For 3D imaging, the image capture is very good, but landmark identification is highly operator dependent. If it is done by a biomedical engineer, errors are known. And that is why in patient-specific total knee, when the landmark identification is done by a medical rep or a biomedical engineer, planning can have errors. When the surgeon does it, the error margin is much lesser. In terms of imageless, we will look at the landmark identification errors in 3 different planes. How do we calculate landmark identification error? It is simple trigonometry. The distance across which the angle is measured. If the error margin here, y, is plotted against the length of the bone, inverse of sine gives you the error margin. So in coronal plane, for a femur of 500 mm, a 2 mm registration error here will lead to an error of only 0.2 degrees. That is why computer navigation has been very accurate and gives you very reproducible AP and lateral X-rays. This is borne out by literature as well, that the risk of malalignment is very low. Same for the sagittal, because it's measured along the same length, it is very accurate. The question is it adequate? Why? Because we know that the femur is bowed. With image capture, we capture only the hip center and the knee center. So we plot only the mechanical axis. We are blinded to the intramedullary axis. And as we know, 11.4% Asians have more than 5 degrees of the femoral bow. So if using technology aided TKR in navigation or imageless robotics, we are blinded and we on an average go with 2 or 3 degrees of flexion. There is no precision there. Placing the femur at 0 degrees of flexion to mechanical axis. Now this was a study done by us, which is a waiting publication, accepted for publication. Placing the femur at 0 degrees to mechanical axis will lead to extension of the femoral component in 39% of patients. It's a huge margin. And probably that is why this paper, a Ranawat award-winning study, 14-year follow-up randomized trial, says do not recommend the widespread use of TKA because of risks of notching and attendant costs. In the axial plane, it's a different ballgame altogether. Why? Because the distance is smaller, so the error margin is much higher. As you can see here, a 2 mm error can lead to a 5.7 degree error in rotation. With the collateral ligaments and the soft tissues, it is very easy to make a 2 mm landmark identification error. And that is why most systems fail in terms of rotation. This was an excellent study of 70 cases comparing CT scan and intraoperative navigation measurements. What did they conclude? That the related navigated measurement is not considered to be reliable and reproducible. So as we have seen, if there is garbage in, there is garbage out. No matter how much calculation precision is there, whether it's 0.1 mm of the robot or 0.5 mm of the navigation, if there is garbage which is going in, this calculation precision does not matter. So just to summarize, with navigation, what happens is there can be a point grab error. It's very accurate for the coronal plane. For the sagittal plane, the surgeon is blinded to the anatomic axis. And it's very poor in terms of axial definition. And probably that is why we've not been able to see consistent results or benefits. Moreover, there is always a risk of increase in operative time, which has been documented to be as large as 23%. With PSIs, image capture is very accurate. The problem lies with landmark selection and the surgeon being blinded to all the characteristics, anatomical characteristics of that patient. That is why this is the Australian registry at 8 years, which says that the mechanical axis outliers were quite similar to the conventional. Imageless robotics uses computer navigation to plot the femur and tibia in 3D. Hence, it is plagued by the same errors, both in terms of image capture and in terms of the sagittal and the axial plane. This was a recent paper. An experienced surgeon can meet or exceed robotic accuracy in manual UKR. But more importantly, the one incontestable fact that robotic cases take more operative time, which is linearly related to complications, particularly infection and thromboembolisms. Are we merely exchanging outriders without clinical benefit for complications without clinical solutions? That's Sharkey and Javed Parvezi, August 2019, Journal of Arthroplasty. That is where probably 3D templating has a role. You save on time and you are accurate. Plus, you have the ability to choose an implant. You can see the amount of overhang. We know that overhanging of more than or equal to 3 mm in one zone can lead to a 2-fold increased risk of knee pain. Another study from France, the same thing. Overhanging in 66% tibia. More importantly, where does the accuracy come from? Planning or instrumentation? This was an excellent meta-analysis and a systematic review for shoulder arthroplasty, wherein 3-dimensional CT scan is basic pre-op gold standard. So what they suggested was that patient-specific 3D templating or planning may have significantly influenced accuracy versus the actual patient-specific instrumentations themselves. One study found no significant differences between 3D planning and PSI, although both improved accuracy. The logical explanation that they gave was that three-dimensional preoperative planning can possibly make the surgeons more cognizant of deformity, such that they make subtle adjustments based on their plan that actually increase surgical accuracy versus the use of the physical guide itself. And if we look at technology in TKR, be it computer navigation, PSI, or robotics, we have moved from either no planning or planning by a non-orthopedic to very precise execution at a huge cost, both in terms of money and time. Albert Einstein said, "I fear the day technology will surpass our human interaction. The world will have a generation of idiots." So 3D augmented surgery, image capture is very accurate. Landmark registration is by the surgeon accurate in 3 planes, allows the surgeon to choose best position for bony gap balancing, make adjustments for soft tissue balancing. Effectively, you are creating a personalized joint from a variety of off-the-shelf implants. Simple, modular, reusable instruments. In the post-COVID era, it's a web-based, work remotely platform, modular, reusable image-derived instrumentation, improved OR efficiency, reduced OT time, less instrumentation, less exposure to the surgeon and the team. Thank you. Welcome, Dr. Premkumar. I guess there has been one question from the audience so far on this one. So I guess we'll take that one. And that is, are cutting jigs different for different companies? Yes, they are. So the one you saw was for Evolutus, for Roloflex Tonic. And I think we have Dr. Patrick from France eagerly waiting to share his thoughts on Roloflex Tonic. Please, sir, share your screen.
Okay. Can you see me? Okay, can you see the
Yes,
screen?
sir.
Yeah,
we can see. We can.
Okay.
Yeah.
I must apologize for my poor English. I hope you will be able to understand me. And if you have any problem for the speaking, you can ask me, of course. We have to speak about the 2 variants of the Roloflex Tonic total knee arthroplasty. As you know, we have 2 variants, ultra-congruent and posterior stabilized. The purpose of the conversation today is to speak about the respective indications and technique. First, before surgery, to have a good result, we have to make sure to have the right candidate. It means the good patient has a mechanical pain and of course a total intra-articular pinch on the X-ray. Which choice, UC or PS? The UC is especially for healthier knee with an efficient quadricipital muscle movement. It has a less constrained design and so consequently potentially a reduced wear. It requires a good ligamentary status, which is suitable, therefore, for knee with a low deformity. The PS, posterior stabilized, it improves the kinematics of the knee with the femoral rollback and the quadriceps muscle movement. It has a more constrained design and better stability in case of poor ligament status. It increases with the peg, the central peg, the jumping distance and prevent anterior-posterior dislocation. And it is more suitable for knees with higher deformity. The choice between the two variants must be according to patient's profile. Age over 75 is rather for posterior stabilized. The activity level of the patients is also important and must be evaluated. Chiefly, the most important factor is the muscle conditions. A poor quadriceps strength, which can be tested and evaluated before operation by isokinetic measure, that we do in our center, is an indication for PS stabilized knee. The ligament status, poor ligament status, is rather for posterior stabilized, and the importance of the deformity of the knee. UCOPS, both variants are useful in our practice. The slightly different outcomes between UC and PS allow for the better adaptation to each patient's expectation. The surgical technique uses the same instrumentation set, and it is also easy to change from one variant to the other intraoperatively if requested. Whatever the variant, perfect ligament balancing is of course recommended. The planning, always the same. We have to visualize the tibial cut perpendicular to the mechanical axis. A full X-ray is required, and the goal is to achieve a perfect alignment, hip, knee, and ankle, but we have to take care of the original deformity of the patients, and maybe sometimes we have interest to keep a slight part of varus or valgus to avoid excessive release during operation. How to insert the patient? Never tourniquet, no tourniquet at all. And we use an assistance for tight flexion and extension. Our surgical approach is always a mid-vastus or lateral patella in case of valgus knee with a fixed deformity. We try to do not useless detachment to avoid extensive release. Never ever the patella when the knee is flexed to avoid plastic deformation of the quadriceps and protect the MC health with a retractor. Tibial cut first, always. Cutting guide is always extramedullary to respect the metaphyseal bone and in case of tibial deformity. We try to reproduce the native posterior slope of the plateau. The choice of the femoral valgus to avoid excessive release and to obtain a perfect ligament balancing. Ligament release is a strain and must be avoided if possible. Tibial cut first. After tibial cut, we check full extension and orthogonality of the cut with the 10 millimeter tibial spacer. Most important is the external rotation of the femoral component, which is really the key for successful TKA. In case of neutral rotation, the lateral compartment will be loose in flexion after resection. We have to rotate the gate externally to anticipate square space inflection, as shown on figure C. That's the case here when neutral rotation, we have a loose compartment inflection. The choice of the femoral rotation is based on the landmark of the B epicondylar axis, which is for us the gold landmark. It's rather easy to find it during operation, and we fit the external rotation to the anatomy of the distal femur, and 3 degrees of external rotation must not be systematic. Sometimes it could be 0, sometimes it could be 5 or even 7. Another thing that we have to consider is the choice of the center of femoral rotation. If you do a rotation, we can do a rotation around the femoral guide, it's a central medulla guide, or around the posterior medial condyle. Rotation around the femoral guide is rather suitable for varus knee because the automatic medial release inflection is obtained by the bone cut, which is more important on the medial condyle and is more important than the implant thickness. For valgus knee, we prefer to do rotation around the posterior medial condyle. It avoids excessive medial release inflection. The bone cut is always equal to implant thickness, and it increases the thickness of the prosthetic posterior lateral condyle, which is always too thin in valgus knee. To check the femoral size, we have to respect the posterior condylar offset. When we cut more than 2 millimeters less of posterior condyle, that amounts to a loss of flexion of 12 degrees. We have to respect the posterior condylar condyle to avoid conflict inflection early, and we prefer for that to use a 3 degree of sagittal flexion to avoid an mediolateral oversizing and or a notching. For the distal cut on the femur, we don't hesitate to increase the distal cut to obtain the same gap in extension and in flexion. Resection, you know that resection of the posterior cruciate ligament increase the flexion gap of at least 2 millimeters. We have to select the thickest spacer possible, but suitable with the full extension of the knee in order to have no residual flexion. Posterior cut. Be careful with the medial collateral ligament. Use a refractor to protect the ligament from the sole. The resection of the posterior osteophytes must be compulsory to prevent an early contact with the polyphyline inflection, which could occur wear and flexion limitation. In case of preventing imbalance inflection with a student spacer, use a posterior stabilized prosthesis, not an UC. For the tibial, we select always the maximal tibial size to cover the tibial plateau, and we don't tolerate an epilaxity inflection with an ultracondylar prosthesis. we finished by injection of ropivacaine in periarticular behind the posterior capsule before implantation of the component in the lateral and medial capsule in patellar tendon and in medius medialis. Component implantation, first tibia, then polyethylene, and then femoral component. Rapid recovery, no drain, tranexamic acid 3 grams in intra-articular injection, pain management in postoperative stage. And in the afternoon, the patient is settled in the armchair at the end of the day and encouraged to move actively the knee. Thank you for your attention. Okay.
I guess we haven't received any questions as yet. So, and Dr. Premkumar was having some time constraints. So we'll start off with his minimally invasive talk on Roloflex tonic and on valgus knees. So Dr. Premkumar, please.
Sorry?
Can you share your screen? Yeah, Premkumar, you'll need to unmute yourself.
Yeah.
Yeah.
Yes. Can you hear me?
Yes, now we can.
Yes. Okay.
Can you share the screen?
Yeah. Save the messages.
And you have a huge task of taking on from Dr. Patrick, who has delivered a fantastic talk on Roloflex. Yes. So over to you.
Yes. Can you see the screen?
No.
No?
Not yet. Not yet. Not yet.
Any problem?
Smriti, any questions so far?
As of now, we haven't received any.
Okay. Yep. Now we are
Can
seeing
you see my screen?
Oh, yes. Now we can.
Yeah. Yeah. So I will go to my the valgus knee balancing technique first. Can you bear with me? Hello.
You'll have to do the full screen.
Yes, we can hear you.
Yeah. I shown the full screen. Is it okay? Hello. Manish, is it okay now?
No, it's not yet full screen.
It's a full screen here. Here in my laptop, it is full screen. Let me see. Is it a full screen now?
No.
No, it's okay here. Any problem?
No, we're still not seeing the full screen there.
Oh. How do you see now?
No. Because we can see your favorites, we can see the...
I have shared my screen. No, I have already shared.
Okay.
Is it that okay?
Okay. Can you move ahead on the presentation? Let's see if it moves on.
See? Yeah. How do you see now?
No, it's still on that initial screen only. It's not moving.
So you could probably stop sharing and reshare again.
Yeah. Okay. So where I have to go now for that?
That's at 12 o'clock.
Yeah. Here is a new share. Yeah. I can share the screen. Now I have done the I've done share the screen.
And
Yeah.
you,
What do you see now?
yes, much
Okay,
better.
okay. Yeah. Now you see?
Yeah.
Oh,
Now we
thank
are
you.
there.
Yeah.
Okay, thanks.
Okay. See, good afternoon. This topic is how to manage the valgus knee. It's really a nightmare for the surgeons. And I don't claim it is a very new technique, and it's a little bit modified. I have put my own innovations here. And I dedicate this concept and this talk to my poor patients with severe valgus deformities. See, these are the kind of valgus deformities we are facing here in Kerala. It's a south of India, and the patients come to us when they are literally not able to walk, maybe 20 to 25 years after developing this deformity. Okay. See, usually the valgus deformities are multiplanar, can have varying degrees of flexion and external rotation of the tibia, and usually there is a hyperextension. Flexion deformity is very rarely seen except in rheumatoid arthritis and other inflammatory diseases. See, you have to assess your valgus deformity. There are mainly two components. One is the bone part, other is the soft tissue part. On the bone part, the problem is the lateral femoral condyle. Can you see me? Hello, can you see me?
Yes, we can see you.
Yeah. So I'm showing a knee model. Is it see you?
Yes.
Can you see Manish? Yeah, okay. See, you have to assess the lateral compartment, the lateral femoral condyle and the lateral tibial plateau. And the soft tissues, here it is iliotibial band, this LCL, and the popliteus tendon here, and the posterolateral capsule and its hamstring. See, the algorithm which is available in the literature is something like this. If it is a mild, means 10 degrees of valgus deformity, then you have to release the ITB and the lateral capsule. When it is between 10 to 20 degrees, then it's called moderate deformity. Then along with ITB and lateral capsule, you have to release posterolateral capsule with a pie crusting. You can flex the knees and do the pie crusting here. If there's a severe deformity that is more than 20 degrees and up to what it is not mentioned, you have to release the popliteal tendon and the lateral epicondyle. They are advising to do lateral epicondylar osteotomy. If the surgeon follow this algorithm, you will land up with a severe soft tissue releases. Ultimately, your knee will come totally unstable. Okay. So then you are forced to use the constrained knees, TC3, something like that, and the hinge knees. So these implants eventually fail. They won't last like other conventional implants with a less constraint. These constrained implants usually fail maybe between 5 to 10 years time. So we need to achieve a balance between the deformity correction and the stability. So I am advising you to reassess the deformity again. Say whether your deformities exist only in extension. The valgus deformity is only in extension. Then you try to check it. Whether it is present, the valgus deformity is present in flexion too. It is valgus and also in extension, because both these conditions are entirely different. And you have to see your valgus deformity is correctable or not. If you use a little bit of varus force, your valgus deformity is correctable or not. The structures that origin close to this epicondylar axis of the femur, like the LCL, the popliteus tendon, and the posterolateral corner capsule. They have some effect on flexion and extension almost equally. But LCL is more active in extension. The popliteus tendon mainly in flexion. So these are the things we do on table. You have to release iliotibial band. Then you can see here, this iliotibial band has no effect on flexion. Here it is fully relaxed. Now in flexion, this is a popliteus tendon and the PCL behind. With the posterolateral capsule. So this is the way we are advising to do the pike resting. See, if there is a severe bone loss on the lateral side, there is my first X-ray. If there is a big defect, the bone loss on the lateral side, and with a severe deformity, that means your MCL will be very much elongated and attenuated. If there is no bone deformity here on the lateral side, and there is a deformity, then only you have to be very careful. If there is a bony deformity, it is femoral condyle, lateral femoral condyle is dipping into the lateral tibial plateau, then your MCL lengthening is almost less. But when there is no bone loss or less bone loss, then your MCL will be overstretched and attenuated. If you do lateral release to equalize the tension of both the ligaments, you will land up with a limb lengthening. Understand that? See, MCL is already elongated, then you have to equalize both the ligaments. You have to do a lateral epicondylar osteotomy, then your limb will be lengthened. In several occasions, you have to put 15 mm or 18 mm poly. So then what's the solution to prevent this limb lengthening? See, there is a literature shows you have to do a medial epicondylar osteotomy. Whenever there is a elongated or lengthened attenuated MCL is there, then you should not release on the lateral collateral ligament. Then you have to release MCL or you do a medial epicondylar osteotomy. Then your limb length will be very well preserved. See, we like to say when the valgus deformity is more than 30 degrees, we call it as a mega valgus. See, this is a line of osteotomy we are advising on the medial side. So we have done a cadaveric study, and this is a dissection that we have done on the cadaver. See, after your femoral, tibial, all cuts have been over, you can do whether meshea resection or balancing tube. Then after all your cuts have been finished, you have prepared femur and tibia, you can go ahead with the medial epicondylar osteotomy. You can mark it the way we have done here. See, you should try to select a big chunk of bone on the medial side. Otherwise, you won't be able to fix it back. You try to fix it, it will splinter or fracture. To avoid that, better to have a good chunk of bone on the medial side. And this video I already have shown you, yeah. And how to do the implantation. Yeah, your cuts are over, and I am showing this in a mobile bearing, knee, and I have already done this middle epicondylar osteotomy, and yeah, and you put your tibia and the femur and the femoral component, then you try to extend it. I'll be showing the same surgery on the patient. So after the implantation, you keep the knee in straight and keep the knee, this valgus is corrected in a neutral position, and try to find out where your middle epicondylar bone piece has to move proximally and little bit anteriorly, and then you fix it. Usually we advise to fix it with a 6.5 partially threaded cannulated screws. If it is cannulated, it's easy. You can pass a guide wire first. Always try to fix with 2 K-wires. One will be stabilizing always, and the other K-wire is used as a guide wire. And you pass your 6.5 cannulated partially threaded screw. It's optional. You can use washer or without washer. Then you don't over tight it in this location, because if you try to do over tightening, it can cause a splinter. Okay, now see, after the middle epicondylar osteotomy, fixation is over and your knee is stable here. And how do we do the same thing in a valgus knee? Just watch here. See, all the cuts are over and we have done the implantation too. The implants are in position and I'm checking how much is the valgus here. So you have already seen here. See, it's a neutral, and I show you one second. Yeah, this is almost 25 to 30 degree of valgus. Yeah, more than 25 degree of valgus. So after cuts, all the trial implants are put and we remove this. Even the mobile bearing is possible. They remove all these implants out. Yeah. Then you can mark the osteotomy with a cautery where you're planning to cut it. Ideally, I repeat it, you should take a good chunk of bone. Otherwise, you won't be able to fix it. It is little different from the lateral side. Lateral side, even if your lateral epicondylar osteotomy bone splints, and if you don't fix it on the lateral side, doesn't matter. But on the medial side, you require a good quality bone and a good chunk of bone and a good fixation. And I advise you not to use any saw on the body. If you can do it with a sharp osteotomy, it will be more advisable, because the saw blade will remove a lot of bone. Roughly 2 to 2.5 mm of bone will be lost on the osteotomy side. If you do it with a little bit, this kind of a broad osteotomy, you can gently do this job. See, you will be terrified because I'm removing a good chunk of bone on the medial side. See, we are doing a medial epicondylar osteotomy. It's a big chunk of medial epicondyle with the elongated MCL is separating from the parent femur. You can take little bit time over this area. You can do it gently. Yeah. Now the osteotomy is completely over. Yeah. The next go. In the postoperative care, we give a hinge knee brace for 6 weeks and a knee flexion and mobilization as usual. And the patients will be walking with a knee brace and a walker. And this is that particular patient. Yeah. Walking with knee brace and a walker. The only advantage here is your limb lengthening is avoided, and you can use conventional implants, less constrained implants, even mobile bearing implants. You can avoid highly constrained implants and hinge knees because their life is short. Okay. Yeah. See, we have done 8 patients since 2012, follow for 6 months to 3 years. All patients had a good results, and the knee society score was 45 to 55 points, and the patient had a 90-degree of flexion in all except one patient. And I show you a few examples. This is a one patient of 70 years old lady, and see, this is the way she was walking before surgery with a severe valgus deformities on either side. This is after the surgery. Yeah. Yeah, this is a preoperative X-ray. This is a postoperative X-ray. Okay. There is another patient. You have seen her valgus knee. This is a valgus here is almost 10 to 15 degrees. And this is a postoperative peak. And this is a result after his surgery. And this a guy is walking. Yeah. So see this patient of more than 35 degrees of valgus. It's a pre-op, the post-op, and this is where she was walking before. See, and this is an immediate post-op after a month, and it is after 6 weeks. We have removed the brace, and here this right knee is stiff. She is not able to flex it. This the left knee is we operated. Yeah, she's a severe rheumatoid arthritis with a fixed right knee. It is stiff in extension. The left was almost 40 degrees of valgus, and we operated. This another cases. Yeah. So thank you.
Thank you, Premkumar. That was an exhaustive series on valgus knees. Can we have a few questions?
Yeah,
and
sure.
The first
sure.
one from Dr. Patrick is, when would you use a lateral approach? Would you normally stick to the anterolateral, or would you use something different for this kind of valgus knees?
Because I'm not confusing everyone. Even these kind of cases, we are using a minimally invasive technique. And even that is a subosteus, I do. Subosteus minimally invasive techniques, even in any kind of valgus or the varus knees. But I'm not advising the guys, the beginners in this field, better to, we all are well versed with the paramedian approach. You can do this work with a paramedian approach. But there are surgeons, they advise valgus. I have done valgus.
Dr. Bharawaj, any experience with this lateral approach?
But I found it is a little bit difficult for me. Median approach, paramedian. But usually my surgery is minimally invasive subosteus approach.
I have tried lateral approach in certain cases, and every time I had a more difficult time than I would have been having if I would have used my standard paramedian approach. but you know that at times you just feel adventurous or think something. And every time I have done this lateral approach, I've actually thought that it was more of adventurism than anything positive which would have come out of it. It could be because of my limited experience of doing a lateral parapatellar, but yeah, I seldom enjoyed lateral parapatellar.
Dr. Patrick?
Yeah.
Yes, sir. How are you? I
How are you?
visited you in the last August. I think you remember me.
I remember you. Yes, of course.
Yeah. Thank you, sir.
And what is your experience with the lateral approach, Dr. Patrick? Because you had mentioned in your presentation that
yes, I use lateral approach in case of big deformity in valgus and a fixed deformity, not correctable. So in that cases, it could be difficult to have a release of the soft tissue on the lateral side with a medial approach. So I prefer to do lateral approach, and like Cavendish, to do osteotomy of the tibial tuberosity to have an evasion of the patella and extensor mechanism, and to avoid palsy of the sciatic poplite. That's very important. So we can have a luxation of the tibial plateau to prepare the plateau correctly, and then to do the release. Of course.
And you had mentioned in your talk that for valgus knees, you base your rotation on the posterior condyle. How do you do it?
With the instrumentation, specific instrumentation of the Highflex, of the tonic, we can choose the center of rotation, and we can choose the center on the medial condyle. That will avoid too much rejection of the bone on the medial condyle and increase artificially the thickness of the lateral condyle to have a more stable knee after, and to have a good balancing, even balance inflection.
The cases that Dr. Premkumar presented, firstly, I'll ask Premkumar himself, how many of those patients needed an extension rod or a tibial augment?
Only one patient, because when it is a very osteoporotic femur, and when the bony defect on the lateral side is almost more than 10 millimeter or above that, it is better to use a tibial rod. Femoral rod I never used in valgus knees.
In these kind of deformities, Dr. Bharawaj, how often would you use extension rods on the femoral side and on the tibial side?
Honestly, no, many times. I've been a conventionally a cruciate retaining surgeon, and most of time I'll get away with a cruciate retaining also in a valgus knee. But it's only when the ligaments are actually stretched in terms of moderate deformity, then I'll always be ready with a semi-constrained option like a TC3. And for that, I need to use the rods, because several of these patients are rheumatoid also, and you don't want to put too much into them. So yes, I do have a backup of stems ready and a semi-constrained options in these cases.
And regarding the concept that Dr. Premkumar has put in, see, normally we are used to making the tight side loose. Here we are talking of tightening up the loose side. That is the medial side. We want to tighten the medial collateral. What would be your experience of an epicondylar osteotomy, be it for release or be it for tightening? Any experience, Dr. Patrick?
Sorry, I did not understand very well the question. You were.
Do you use an epicondylar osteotomy to balance the knee?
No, never. In case of valgus knee, of course, I never do it. But I think the most important fact is to do a minimal tibial cut, not never 10 millimeters, always under 10 millimeters, maybe
Under
6 or 7 millimeters, to avoid to have a too big, too thick spacer insert. That's the most important point to begin. And then we have to go step by step to have a good balance.
Dr. Bharat, epicondylar osteotomies?
I know about it, but never had to do it practical so far.
Great. Then I guess we can move on to your gap balancing and then come back for another round of questions.
Yes. Thanks very much, Dr. Shah. I think the most of the gap balancing has been covered in the previous talks. And the reason I came to gap balancing was the thinking problem that at times you think that how you can optimize your results, and the training purpose is not to fill the fixed facts. It helps us to evolve into our own thinking, try to improve ourselves with constant thinking. Now, as we all know, that the success of a TKR collectively depends on a proper joint line recreation, appropriate soft tissue tensioning, respectful management of the extensor mechanism, so that we can re-establish proper knee kinematics through both medial lateral and flexion extension ligament balancing.
Dr. Bharadwaj, we can't see your screen. Can you share your screen?
Oh, I think it was getting shared. Okay. Is it? Can you see it now?
No. Yes.
Yeah.
Now we can.
Okay. Okay. So you are getting business now. So the idea of gap balancing in the knee came as the side effect of constant thinking. You want to improve your own achievements, you want to improve your results. You do find in certain cases the things are not going as you would like them to be. And as part of a training, you are told to think and not merely following what everyone had been doing. As we all know, the success of TKR depends on the proper joint line recreation, appropriate soft tissue tensioning, respect of the extensor mechanism, and re-establishment of a proper knee kinematics through both mediolateral and flexion extension ligament balancing. Patient outcome depends on establishing acceptable component alignment, soft tissue tensioning, and obtaining rectangular, evenly tensioned and symmetrical flexion extension gaps. Surgeons employ either the measured resection or gap balancing techniques to achieve these goals. And actually the essential difference between two is the workflow, that how it goes. So in the gap balancing, ligaments are released first before bony cuts are made. Surgeon determines femoral component rotation by cutting proximal tibia and then using a spacer to determine the femoral rotation. And it's not only femoral rotation, it's actually also the femoral translation and component sizing. It relies less on the intraoperative bony landmarks, because goal is to obtain a rectangular, evenly tension and a symmetrical flexion extension gap. Now, it mainly starts with removal of all osteophytes. So we are dealing with the soft tissue envelope first before we start making our bone cuts. Removing osteophytes are important because they tent the ligaments and may produce a flexion gap asymmetry or femoral component malrotation. It also goes that the PCL also has to be removed as a first part so that we can access the posterior part of the femur and the tibia also to remove the osteophytes. The success of gap balancing is tied to the accurate tibial cut because we are putting a spacer on the top of the proximal tibial cut, and if this tibial cut is in the valgus, we can externally rotate the femur much more than is actually needed, and if it's a varus cut, then we can internally rotate the femoral component. Gap balancing involves the tensioning of the ligament, so collateral ligament integrity is the must requirement when we can start the gap balancing, and therefore gap balancing should be carefully undertaken if there are fixed deformity, because if deformities are not fixed, if they are fixed, they are not flexible, then gap balancing may actually throw us off. Now comes the measured resection, which is a default technique with most of the surgeons. It is characterized by use of bony landmarks to determine the femoral component rotations. And as we are all aware, there are mainly three femoral anatomical landmarks we go after, which is trans-epicondylar axis, AP or wide side lines, or posterior condylar axis. In measured resections, bone cuts are made before soft tissue tensioning is done. So as we know that the AP axis or the wide side lines, the axis of rotation should be 90 degree to it. It should be in line with the trans-epicondylar axis and 3 degree external rotation in relation to the posterior condylar axis. But as we all know that these bony landmarks can be regularly misidentified, as surgeon may fail to identify the key bony landmark because they are not a single spike which can be every time picked up. It's a diffuse dominance, and like Dr. Shah told in his talk also, that by law of trigonometry, if the distance is short, even a small error can throw us a big angular inconsistency. So these are the three landmarks which are followed in measured resection, but due to faulty identification of these landmarks during surgery, the rotation of the femoral component can be compromised. Flexion space imbalance or instability is a recognized factor adversely affecting the patient outcome. Important factor for this imbalance is the malrotation of the femoral component and or incorrect soft tissue balancing. Now, when the patient comes in the follow-up, there are certain symptoms to look for which actually suggest that this patient may be having a flexion instability, which is subtle enough not to cause a dislocation, but it actually giving him or her trouble. They'll give history of recurrent effusions, stiffness, inability to trust the knees, especially on the stairs. They'll describe the point tenderness over the Gerdy's tubercle or on the pes anserinus region, and poly can wear quickly because of the shear forces exerted on poly by this flexion instability. If a femoral component reproduced anatomically, then there is a rectangular flexion gap, a lower incidence of condylar lift off, improved patellofemoral tracking, and better femorotibial kinematics. Gap balancing gives us a desirable outcome. Balancing is done independent of the bony anatomy, and it gives us a better femoral rotation, sizing, and placement. So as the flow goes in the gap balancing, first of all, we go for the resection of the tibial proximal cut with an extramedullary jig. I take off the 10 millimeter off the proximal end of the tibia, and then we are checking the flexion and extension gap. As I have taken 10 millimeter of the tibia, so if I use a 10 millimeter spacer, I should get the knee straight in extension, and the same 10 degree, 10 mm should be in flexion also. But what happens in flexion? Because of the normal tibial vara of 3 degree, there will be laxity in the lateral compartment. Now that laxity is measured in this system by using a hemi augment of a 3 millimeter generally, but there are option of from 1 to 5 millimeter. Now this whatever this hemi wedge we have used to tension the lateral side, we need to remember it because that will determine our external rotation. And then I use a link cut system, which is a jig, which is dependent on the proximal tibial cut. So say I had used a 10 millimeter spacer for flexion extension. Then I add 2 hemi augments of 4 millimeter under the 6 millimeter tibial base plate. And that becomes a receptor for my link cutting system. If I have used a 3 millimeter hemi augment to tension the laxity on the lateral side, I need to attach the same 3 millimeter wedge on the lateral side on top of this jig. I drill an intramedullary rod, and that's how on the table this assembly look like. The intramedullary rod is in place, the tibial base plate is in the place, and I slide this link system which engages with the tibial plate. Now with the stylus, I take the size, and the gap balancing is doing all the rotation, sizing and placement of femoral component for me. Once I have made the cuts, I check the gap again in extension and flexion. It's not a big deviation from the technique which we are aware of, but this gives me a consistent outcome in terms of my femoral component positioning and the range of movement at the knee. I am showing some of my satisfied patients using this knee system, using the gap balancing with this linked cutting jig, and I'm really pleased with the consistency of the results I'm getting in my patients. They have got excellent range of movement. They all have smiling faces, and it's one after another. I can keep showing you these results, and this is one requirement which keeps coming from our patient. And with this system from Evolutis, I can actually deliver what they had been asking for. So that's all from my side. Thank you very much. Any questions?
Thank you, Dr. Bharawaj, for that excellent talk on gap balancing. Dr. Patrick, how often do you use measured resection, or do you use only gap balancing?
Most part of the time, I don't do bunny resection, and I can. No, sorry, I do resection, bunny resection to have a good balance, and I avoid at the maximum to do a release of the ligament to avoid stiffness and pain after surgery.
Premkumar, your experience with gap balancing? You'll need to unmute yourself.
I started my career with a measure resection from the institute. I think I have done very few gap balancing cases with Dr. Bhan names. And when I came back to Kerala, I think I have done the largest number of mobile bearing knees. And especially this all mobile bearing knees works on the gap balancing. I don't think there is any design which is available with a measured resection for the mobile bearing knees. But it is better to do because gap balancing, I feel gap balancing is the technique for doing a knee replacement. And there is a talk in, I think, 2006, 2008. There's a publication, it shows this measured resection is an outdated technique. Because many times, if you do a measured resection is a bony surgery, and you cut 8 mm from your femur, 10 mm from your tibia, femur and tibia is finished, then you release accordingly, then you put your whatever the poly which fits in. And that measured resection, I personally feel, yeah, I don't know, what's your opinion about this? And I feel we should train our juniors to do a good gap balancing this. That gives excellent result.
You stirred a hornet's nest.
Actually, if I have to see it, that in the major dissections, the soft tissue release is being done after the trial component have been placed. So basically, we are at times trying to justify what we are already committed to.
Yeah.
Like telling my associate, "Itna to chalta hai, chal jayega." It will do because now we are committed. Once we have put the components in, the trial components in, and we have made our cuts, so we are committed. And it's the femoral condylar lift off, because I've been trained in UK, spent good part of my life there. So in my blood, it's the CR surgeon, and I had been doing this. But the only reason which I had to convert to a gap balancing is the condylar lift off, which you see at times because of your flexion gap asymmetry. You try to release it by sometime by popliteus or some structures, but you know that it's just a compromise here. I was looking for a system which can provide me a toy, a reproducible toy where I can use the gap balancing, because doing a gap balancing with the laminar distractors on and doing this improvisation was not coming to me. So with this tonic roll flex, with this linked cutting system, I have got a reproducible instrument where the gap balancing is actually working. I have done around 100 cases with the gap balancing, and so far I am pretty pleased with what I've been seeing in my follow-up. But yeah, it's the first time I'm trying gap balancing. I was never trained on gap balancing. I was always trained to be a CR surgeon.
Okay,
Can
I'm going to put in some more questions. Yes, go ahead, Premkumar, before I put in those questions.
Yeah. The main difference between the gap balancing and the measured resection, you might have heard a lot of talks, gap balancing versus measured resection. What I understood that only in gap balancing, you can equalize, you create a flexion gap first, because you have to cut the tibia first, then you create a flexion gap. After the flexion gap is created, then you go for a variable extension gap. You cannot do this if you have created an extension gap. It is really difficult to create a equal flexion gap to the extension gap that you have already created. You have variables only on the extension side. You can increase the cuts on the distal femur less or more. Accordingly, you can adjust the extension gap. But on the flexion gap, you have to undersize or oversize your femoral components. That's the only way you can equalize your flexion gap to the extension gap. Otherwise, you have to do a navigated or a robotic knees.
No,
what do you say, Dr. Manish?
Dr. Manish has given me a lot of ideas, and I'm actually thinking to visit him soon to see his toy. I'm really impressed what he had been showing. Really impressive.
The thing I believe is that probably at some point, measured resection meets gap balancing. Because, okay, that is the question that I was going to put in, is to all those who say that we should be doing only gap balancing, what is the amount of correction that you want to achieve before taking your tibial cut? Dr. Bharawaj, we'll begin with you.
Yeah. See, like I said, that if it's a fixed deformity which can't be passively correctable, then one has to be ready that probably he'll fall back on the old tested system of measured resection. Because for gap balancing to be deployed, the deformity should be flexible. So as I start with my exposure of the standard medial exposure, go till postomedial capsule, release the postomedial capsule in a varus knee from posterior to anterior, not crosses the midline of the coronal plane of tibia, and I try to look at any osteophyte which I can see after removing the postomedial capsule. Then I release the PCL from the notch with my diathermy completely, so that my gap opens up and it gives me a bit more space to go behind my knee. If I can correct the knee in extension, then I am continuing with the gap balancing. Even when I am continuing with the gap balancing and I see the laxity of the ligament is actually too much, then I know that something somewhere is not right. And like you mentioned, then come the hybridization of a technique where I fall back on the anatomical landmark and then try to correct it.
And probably that is what we heard Dr. Patrick say as well, that for the valgus knees, the normal is that you take much less of the distal femur. Why? Because then you know that the flexion gap will need to be balanced to the extension gap. These patients will end up with a larger gap. And that is why you want to decrease that extension gap. You take off with a less distal femur cut. Similarly, you set your rotation similarly, looking at how your tibial cut has gone. So at some point, everyone, even those who swear by measured resection, will say that, yes, we do these things, which are effectively gap balancing techniques. Similarly, all those who follow gap balancing will tell you that, yes, we do 70–80% of our releases earlier on before even taking the first cut, and ensuring that the limb is more or less straight. So effectively, the question between gap balancing and measured resection is that with measured resection, you fine tune with small releases, whereas with gap balancing, you fine tune with those small variations in your bony cuts. But the large part of the soft tissue correction needs to be done at the soft tissue level. A large part of your bony correction needs to be done at the bony level. Dr. Patrick, your views on what has been discussed so far.
I would like to tell you how I do in practice when I begin total knee arthroplasty. First, always tibial cut. Then I use, before cutting the femur, I use a spacer of 8 millimeters in an inflection to be sure, but I can enter the spacer inflection. If I cannot do it, I will do a little bit more of the cutting, a little bit more the tibia. Then I go in extension, and to be sure that I can enter the spacer of 8 millimeters. If I cannot do it, I will increase the distal cut of the femur 2 millimeters more, and then when the cut is done, I do the check with the spacer 10 or 12 millimeters and check the balance, the gap balancing, if the balance of the ligament. If the medial compartment is too tight, I will do a very short release. And then I do the same in flexion, but I will use the rotation of the femoral component to achieve a good balance.
Premkumar, anything to add here? You're muted yourself. You need to unmute.
As you asked, how far you release your soft tissues before you do go for the gap balancing.
Yes.
Definitely, your deformity should be well corrected before making any bony cuts, especially if you want to go by the gap balancing. But if you are with your experience, you don't have to be that stiff. You can accept some amount of valgus or varus. Maybe you have to. You should imagine how much deformity is remaining. You can release your soft tissues judiciously. But all your deformities should be corrected in flexion when you have to go for a gap balancing. Even if there is some deformities present in extension, doesn't matter. In gap balancing, first you do the tibial cut, then your deformities on the flexion, it should be well corrected. You have release your osteophytes and the collateral ligaments releases, because these are the two things which affects in the flexion gap. Most of surgeon forgets to remove the osteophyte overhanging on the femur, because your osteophytes under your collateral ligaments will cause some amount of tenting, and that you will misfire in your flexion gap. So try to remove all your osteophytes. Definitely all surgeons remove osteophytes on the tibia, but some forgets to take osteophytes on the femoral part if you go with the gap balancing. And tibial cut first is my take. I always do femoral tibial cut first, then whether you do measured section or gap balancing, and yeah. And what is your take? What do you do?
Yep, I'm also a tibia first guy. Earlier, I started off as a femur first,
yeah.
But then you learn and you realize that tibia first is a lot simpler method, and it allows you to judge your rotations, your gaps much better. That once again brings us to the last part that you mentioned. You can have some variations in your varus valgus. So I'll put that first up to Dr. Bharawaj. For a grossly varus knee, would you correct to full or would you undercorrect a little? Similarly, for a valgus knee, would you correct to 0 or would you leave a small amount of valgus?
See, the aim always is to correct completely, especially the valgus. This has been my understanding that if I leave a bit of valgus now, this knee will drift back into progressive valgus. So I can accept a bit of varus left in terms of lateral laxity, not the medial tightness, but the lateral laxity. Just 1 to 2 millimeter of opening I can accept. When it comes to accepting the valgus, I'm always skeptical that once I leave slight valgus, the tight ITB and structure will keep pushing it. So with valgus, I try to achieve full correction.
Dr. Patrick?
Yeah. In valgus, I'll try to get a full correction. But in varus knee, I prefer to keep a slight varus at the end of the operation to avoid pain on the ligament. And I think it's better to keep 2 or 3 degrees of varus at the end.
Premkumar?
Yeah, that's a new concept has come up. It is always better to keep, if your ethnic population has got a, or basically this patient family has got a 2 to 3 degrees of varus knees before they become deformed varus knees, it is better to retain it, because their knees or the hips and ankle joint will tolerate only that 2 to 3 degrees of varus. If you bring back,
varus.
yeah, constitutional varus, exactly. That's, yeah. I had to ask a question to Dr. Bharadwaj. If there is a 25, 30 and above degrees of valgus knees, then if you don't do a medial or the epicondyle osteotomies, then how do you manage?
It's the Ranawat technique which I follow. Like I said that I've tried to explore the lateral parapatellar more because of the patellar tracking than anything else. For using a lateral parapatellar, my philosophy has been not to the easy access to the structure I can release, but to maintain the patellar tracking better because I've left all the medial structures intact. So, but most of the time I do go medially, and I do it like the Ranawat thing, that first the posterolateral capsule and then flexion extension, popliteus tendon in the end, if I had to, or pie crusting of the ITB as in a medial lateral. And I'd never come to a stage where I've actually felt, or I felt brave enough to actually take off that big chunk of middle epicondyle which you showed and can slide. There had been cases where in a rheumatoid the avulsion had happened, and I have to distalize it at times because it is already off, and then I use, but that's the tighter side which get avulsed, and then you shift it distally. But voluntarily making a conscious decision, no, I never had to do that.
In severe valgus cases, definitely your medial soft tissue is overstretched. Anyway, whether you do a lot of releases on the lateral side, you are trying to equalize the soft tissue balance with the medial side. But the tissues on the medial side is elongated. So have you ever met with some limb lengthening after you are...
That has happened to me because you take minimum from a tibia to fill that gap.
But limb is lengthened, no? See,
So
Dr. Patrick also has told in severe valgus cases, take a minimum tibia. See, if you take a minimum bone and you are taking 5 mm of bone and replacing that tibial part with a 10 mm of your implant, means you are lengthening your limb by 5 mm further. It's very simple. Then when there is too much of laxity on the medial side, Dr. Ranawat is also advising to go with the constrained knee. They're saying don't think too much, you put TC3 or you put hinge knee.
TC3 is always a backup.
See, what we are saying, we are a good surgeon. We all are good skilled surgeons. Why do you want to put this constrained or the hinge knees? Just if your MCL is too much lax, if you release all stable structures on the lateral too, your knee become unstable. The structures on the lateral side is tight, agree, but they are stable. If you remove that stable also, then the knee becomes unstable. Then you have to use TC3 and or the hinge knee. See, your tissues on the medial side is lax and unstable. Then you stabilize that part. Start thinking on that side. And
after seeing your talk, I think it's one of the technique which is very important in one's armamentarium. And once the thing comes, we'll come to God's own country and see that how you play this magic.
Believe me, this Dr. Manish, this I'm doing mobile bearings. If you do middle epical osteotomy, you can do even mobile bearing. You don't have to go to this even conventional, less constrained. I have operated with a Dr. Sanchetti in Salem live surgery workshop. He operated he took a varus knee and I took a valgus knee, and I did the same thing in Salem. See, it is possible, but everybody is following with our old teaching. Do the ITB release. You don't have to release ITB in all cases of valgus knee. If it is present only in extension, you have to release ITB. But all our surgeons are releasing ITB in valgus knee. ITB is released when a valgus with extension.
Okay. One question, Premkumar. when we examine clinically, would you look for whether there is a genuine MCL insufficiency or is it overstretched? Because I can understand that when you do the medial epicondylar osteotomy and you tighten up the MCL, it has to be that there is no insufficiency, or I mean, there's no the ligament needs to be intact. It just needs to be stretched out.
Yes, stretched.
Have you ever found that in any of the cases you were planning an osteotomy, but there was a rupture of the MCL and you had to abandon the procedure and do something else?
No, I haven't seen a case of MCL rupture in any degrees of valgus. I have done a valgus within 80 degrees, severe crippling. Patient came to me with crawling. I have video of that too, because I didn't show, because what I found that the Zoom presentations all are hacking all the videos and all. So that's why I cut. I had enough videos there. So I that stopped in between. So all in, even if any degrees of valgus, this is MCL with a deep, thick part and a very broad superficial part of MCL is never ruptured. It's all overstretched. It is very easily stretchable ligament in contrary to the LCL. LCL is not that stretchable, but MCL can stretch to any level. And the main point here is, if your X-ray shows less bone loss, no much bone defect, then your MCL is overstretched. If there is a big bony defect on the lateral side, your MCL length will be always retained. There won't be any lengthening. In that case, this idea will work. As Bharawaj said, do the ATB release, pike resting, then popliteus release, then lateral capsule, then so and so forth. You release everything on the lateral side.
Okay, and just to take that a little further, stretching it a little further.
Yeah.
Have you considered it for lateral opening in varus knees, doing something similar on the lateral side?
Yes, I have seen.
And
See,
have you done it?
And the lateral compartment in severe varus cases.
Okay.
The point, in contrary to this valgus and the varus, the valgus knees are seen mainly in rheumatoid arthritis and inflammatory diseases, not in large chunk is in that part. There are difference. So the bones will be soft, and there will be a big defect on the lateral side. Do you get me? Because valgus knees are seen mainly in the rheumatoid arthritis cases, and the varus knees comes in osteoarthritis. The bones are really strong. The bone defect will be maximum of 1.5 centimeters maximum, and the patient can have a varus of 30, 35, maximum 40 degrees varus. Not, I can show you that videos also. I have 40 degrees of varus. In such cases, I have seen the lateral compartments of tissue are overstretched, but that is forgiving. But the post-operative cases, that kind of laxity on the lateral side is forgiving because of the biceps femoris. When it contracts, it takes away some kind of laxity on the lateral side, but that is not possible on the medial.
I think Patrick wanted to add something. Yes, please.
Yeah. Okay.
Sorry.
Yes, sir.
Sorry, I have a question for you. How do you fix the medial epicondyle after osteotomy? In which position of the knee? Flexion or extension? You understand what I mean?
Middle epicondyle. Yeah. The middle epicondyle after
osteotomy, would you fix in extension or in flexion?
A flexion or in extension. Yeah, but that is middle epicondyle always fixed in extension.
Okay.
It is very difficult to assess.
It's difficult to find the right place to fix.
Its isometric point location determining is not that. It's all theoretically okay, but that is not required. I haven't faced any problem. If you keep your knee in full extension, correct your full valgus and fix with one K-wire. If you are so skeptical, then you can flex it and see whether this is going ahead okay with your flexion extension. That's a way, look into the isometric point. Then always fixed in extension with two K-wires in place. One you can use as a fixing, and other is as a gateway for your cannulated 6.5 mm partially threaded screws.
All right.
But Dr. Prem, you
Yeah.
are also moving it anterior to look after the flexion laxity also. So you are moving it proximal and anterior both. Proximally
Yeah.
to take care of extension side and anterior to take care of the
Flexion laxity. Flexion laxity. Yeah. Because there will be a laxity in extension and flexion, but the flexion laxity, because mid flexion instability, all these blah blah definitely will be there, because it's not a little bit of eyeballing is there in this surgery. So that you have to bear with. But you have to take care mainly when the patient wants walking in extension. So I used to fix mainly in extension, correct it fully, fix with one K-wire. And if you're so skeptical, you can check, you try to flex it, but practically that is not possible. When you try to flex it, this K-wire will start moving, cutting the bonds, and it will be a mess. So this is a difficult. Sometimes the bond will fracture. So better keep in full extension, correct the deformity, and you can pull it a little bit anteriorly. Ideally speaking, you have to put some ethibond sutures on this bony chang. Then somebody is pulling it, then keep it in extension, then try to flex it. Then you get an idea where exactly it is try to come. Okay. Then you can fix it with KVS. Yes,
we
Dr.
had a
Manish.
great session, and I guess I'll hand over to Sudhir.
Yeah, I just have to leave now. Thank you all. Thank you for a wonderful scientific exchange. We will meet again in future too, because my patient is on table and waiting for me. Thank you. Thank you all.
Thank you very much indeed. Mm?
Thank you, sir. I will see you. We'll meet you again.
I hope
Dr.
so.
Patrick, yeah.
Okay.
Okay.
Very nice. All right. Okay.
Thank you.
Sudhir, we can't hear you. You need to unmute. No.
Okay, maybe okay.
I guess there is some problem with the audio at Sudhir's end. Smriti, would you want to give a vote of thanks?
Sir, I'm Girish here. Thank you for all your participants. Thank you, Mr. Manish sir. Thank you, Dr. Gaurav. Thank you, Patrick. Well, thank you, Suri sir. This is very enlightening and entertaining presentation of TKR, and I hope most of the mysterious areas are covered in a TKR. So, thank you, all of you. Thank you very much. Smriti.
Thank you.
Thank you.
Thank you, Dr. Patrick.
Thank you very much.
Thank you, everyone.
Pleasure to
Thank
be
you,
with
Dr. Patrick. Thank you, Dr. Manish.
Thank
Thank you,
you.
Gaurav,
Thank
sir.
you, Dr. Bharawaj.
Bye, Dr. Manish. Bye, Dr.
Bye.
Patrick.
Bye.
Bye. Thank you.
Stay safe.
Okay.